Thanks for your attention. This is an information video for the general public about management of bowel cancer during the COVID crisis. I'm Paul McMurrick. I'm head of the Department of Surgery here at Cabrini Health, and this is Gary Richardson, who's the head of the Department of Oncology here at Cabrini Health. We're talking today about the situation for patients, the difficulties facing patients who've been diagnosed with bowel cancer during the crisis. So Gary, I'm a patient who's been told by my general practitioner, I've just had a colonoscopy, I've been told that my biopsies show that I've got bowel cancer. What's going to be the usual sequence of events for me from here?
Most patients that are diagnosed will be referred to a surgeon, such as yourself, and a decision-making process will occur that is usually done in a multidisciplinary meeting. That involves specialists of all kinds that treat cancer. You will then have a plan of management that will usually involve surgery first and then potentially subsequent chemotherapy and possibly radiation therapy. The only exception to that is if you have what we call a low rectal cancer, where we often use chemoradiation first prior to surgery. So Paul, what happens when you get diagnosed with bowel cancer?
Well, generally you'll see your GP, and usually that diagnosis has been made on the basis if you're having a colonoscopy and some biopsies, and if unfortunately that confirms the presence of a bowel cancer, you need to be referred to a specialist. That may be a surgeon or an oncologist, depending upon the state of your cancer, and your GP will discuss that with you. But it's important to understand that all of us are still here and working during the crisis, and this is not what we'd regard as an elective treatment. This is an urgent problem and it requires management forthwith. The initial consultation may occur during a telehealth process, either by a phone call or by a video consultation, to make sure that all the appropriate preoperative staging tests and investigations have been done so that we can accurately map out a plan of management. You'll then be discussed at a multidisciplinary meeting and treatment will go on as planned. And if things look favourable and this looks like it can be potentially curative treatment for you, then usually the first stage will be upfront surgery, except under the circumstances that you've discussed, Gary, where someone has what we refer to as a low rectal cancer.
So once I've done all of those things and I've had my telehealth consultation, do I actually need to be examined by the surgeon?
Most patients will come in for a one-on-one consultation. Usually you do need to be physically examined. Not everybody does, however, and occasionally patients will be satisfied with the process of simply a telehealth consultation, but a significant proportion of patients who do have newly diagnosed colorectal cancer or bowel cancer will come in for a consultation prior to the surgery. Absolutely, it's safe for patients to come in for consultation during that time. All patients are screened at the front door to make sure that they don't have a fever. There's a questionnaire process, they use hand sanitizer, and we have strict precautions in the rooms as well to ensure the safety of all people who visit the offices here at Cabrini and at all major hospitals as well. So Gary, I've been told by my specialist and by my general practitioner that I have what's referred to as a low rectal cancer, and that in fact I may need chemotherapy and radiation therapy prior to surgical treatment. Tell me about that process.
That process is made in a multidisciplinary meeting, as rectal cancer is extremely complex. Once it's decided that chemotherapy and radiation are needed, they're used together. And the reason they're used together is the chemotherapy will enhance the effect of the radiation therapy on the tumour, allowing more shrinkage. Treatment will go for a number of weeks, where radiation is usually given daily, Monday to Friday, and it is combined with oral chemotherapy. At the present time, the radiation unit has a secondary screening process so that all patients that make it through the front door of Cabrini will once again be screened before they get into the radiation suites to have treatment. So it is as safe as it potentially can be during this COVID-19 crisis. We use oral chemotherapy so that people do not have to attend the day oncology unit, but also it is equally as effective as intravenous treatment. The great thing about this treatment is it usually does not affect the immune system greatly. So overall, your risk if you develop COVID-19 will be not significantly different than the normal population.
So these patients that we're discussing with rectal cancer who have preoperative treatment with chemotherapy and radiation therapy, how long does that go on for? And is there a break prior to surgery? What's the relationship of the timing of surgery to the chemoradiation?
So depending on the tumour, There are two protocols, one that goes for about 3 weeks and another that goes for a bit more than 5 weeks. And once again, that decision in terms of which treatment you will have is related to the multidisciplinary meeting. Once you have completed the chemoradiation, you'll have a period of a couple of months to fully recover from that prior to surgery. So any potential side effects you may have developed from that treatment will have entirely resolved before you go on and have surgery.
So, of course, that's a relatively small group of patients that we're talking about with rectal cancer. For the vast majority of patients with bowel cancer or colorectal cancer, it's colonic cancer. So the treatment protocol for those patients, how is that different?
Surgery is almost always the first port of call for treatment of colon cancer. The subsequent treatment depends on the results from the surgery, and it depends on the pathology, what is taken out from the bowel in terms of the size of the tumour, how far it's penetrated through the bowel wall, and whether it has involved any of the lymph nodes around the bowel. If you are deemed to be at high risk of recurrence, despite the fact that the tumour has been completely removed, then chemotherapy is recommended afterwards. It has been shown that chemotherapy significantly reduces the risk of recurrence in high-risk patients. That chemotherapy will often go for anywhere between 12 and 24 weeks, and most of it, once again, is oral therapy. So it minimises the number of times that you have to attend for intravenous treatment. Secondly, the treatment does not significantly affect the immune system once again. The immune abnormalities are very short-lived, so overall, your risk of developing significant problems if you do get COVID-19 are not significantly greater than the rest of the population.
So should I defer having chemotherapy because I'm worried about COVID-19?
Absolutely not. The recommendations at present is that we push on with the treatment, and the main reason for that is there is clear evidence that if you delay treatment in patients that are curative, then you reduce their ability to be cured. So you must push on and you must listen to your specialist's advice.
So what happens if I develop COVID-19 whilst I'm on chemotherapy?
If you have COVID-19, then your chemotherapy will be suspended until you have recovered from the infection. You will not be able to restart treatment until you have had negative swabs, which will be done routinely initially and then subsequently during the recovery phase. If you have a respiratory tract infection, particularly upper respiratory tract infection, or bronchitis or something like that, you will be tested for COVID-19. If you don't have it, your treatment would be deferred anyway until the infection has resolved. So Paul, patients that have finished their treatment, that are in routine follow-up, we both look after these patients for quite a few years, and for some they have screening for the rest of their life. How are we dealing with that during this crisis?
It presses on as usual. There's really two aspects to this. One is looking for spread of the original tumour, what we call surveillance for metastatic disease. That should continue as it always has. That can be done during telehealth. As you know, they'll often be seeing both an oncologist if they've had chemotherapy and or follow-up by their surgeon. There's a recognised and agreed program of follow-up tests, including blood tests and generally CAT scans. That should continue on regardless, and that can be easily facilitated through telehealth consultations. And only, in fact, a small proportion of those patients during the COVID crisis will need to come into hospital. The other aspect of follow-up relates to surveillance for second growths within the bowel, what we call metachronous disease, and that involves colonoscopy. Under the current guidelines, if someone's had treatment for a bowel cancer successfully, the recommendation is that they have a colonoscopy every 5 years. So for the vast majority of patients, of course, they won't need to be having a colonoscopy during the COVID crisis. So follow up with colonoscopy to look for subsequent growths within the bowel, what we call surveillance for metastatic disease, under the current NHMRC guidelines. That's only recommended to happen every 5 years unless patients have symptoms. So for the vast majority of patients, that can safely be deferred until after the COVID crisis is finished. If, however, patients have symptoms or concerns, then obviously they can speak with their treating clinician and they'll be investigated as needed. So Gary, any final messages to patients who are being treated now for bowel cancer or have previously been treated for bowel cancer?
First, if you have symptoms, see your GP and go through the process. Don't defer because you are more worried about this virus. Secondly, listen to the government. Don't often say that, but the reality is that you need to socially isolate and you need to be absolutely rigid about your hand hygiene during this. This will reduce your risk of developing COVID-19.